Sai, can you hear us?
Of course, we're waiting for you, Srini.
Yeah.
Lovely, quick overview of TAVR in India.
Yeah. You heard it?
And
okay. Thank you.
Of course,
In spite
good
of
morning,
all,
everyone.
Yeah, we have Dr. Ramesh, Dr. Pratap, and Dr. Dilip with us. You can briefly introduce your case and proceed with your thing. Over to you, Sai.
Good morning, everyone. First of all, thank you all so much for having us with you this morning. Hi, Ramesh. Welcome back to India yet again. Good morning, Dr. Pratap, and everyone there on the podium. To quickly introduce our team, to my right is Dr. YVC Reddy. While he doesn't require much introduction, a prolific coronary operator who does a lot of TAVR work, and he's an integral part of all the structural work we do here. To my right is Sister Karunya. She's been with us for about 15 years. I have Mile, another 30-year stalwart at Apollo. He's our cath lab tech. Moving on to my left, Professor Chandrasekhar. After spending 40 years in Mayo Clinic, he tried to attempt a partial retirement by coming to India. Little did he know that he'd cross paths with us. So we're keeping him as busy as we can. And Ganapati here, who's our cardiac anesthetist.
Sai,
Not to forget Thiru, who's my technical
Sushil?
assistant for Medtronic.
Yes, sorry. Sai, sorry to interrupt.
Yeah.
Sushil is also there with us in Zoom. Unfortunately, because of missed flight, he is not here, but he is able to see you there. He will also pass in his comments in between. Over to you.
Hi, Sushil. Good morning, Sushil.
Okay, go ahead.
So I'm going to quickly introduce the case since we have 20 minutes. Go to the first slide. So the patient is a 69-year-old gentleman, hypertensive, presented with worsening dyspnea since 1 year, severe aortic stenosis, doubtful bicuspid aortic valve, planimetry 0.7, 2+ aortic regurgitation, has rheumatic heart disease, mild MS with moderate MR, good LV function. This is his resting ECG. There's some, as you can see, just LV hedge. These are his numbers. Now, I usually like to start from the left and go one full circle. You can see the perimeter is 83.5. The LVOT is again 82.9. The femorals are large and roomy enough to play football in, 9.410. The only thing is that one of them has a high bifurcation, but we'll get to that later. Go back to the previous slide, please. The coronaries are at 15.6 and 19.2. The sinuses are nice and roomy, 36, 34, 37. So everything is looking like a 34 valve. Could you go forward, please? When you look at this, while initially we were thinking it's a tricuspid valve, if you look at the end-on views of the aorta, I don't like those shadows that I'm looking at. There are a couple of things that I didn't like. One, none of the three sinuses are symmetric. You have one small sinus, two big sinuses. Those dark shadows you see are dense fibrous tissue. You can see these fibrous tissues on the cross-section as well in the NCC, where the heights are showed. You can see a nice big fibrous chunk there. So my gut feeling is that this is a bicuspid valve. This is before looking at the TE, which I'm going to show you shortly. Next image. You can see mild ascending aorta dilatation. You can see less calcium. And again, you can see the dense amount of fibrous tissue. Next. So the bifurcation on the left side is abnormally high. So we just took an ultrasound guided stick on the superficial femoral. The bifurcation on the right gave me enough space to just get it in 1 centimeter above the bifurcation. Next. So points of contention, underlying pathology, tricuspid, bicuspid, with superadded RHD. Treat as bicuspid or tricuspid. All the supraannular measurements are in favor of a 26 valve. So 26 or 34 valve. Predil or no predil. Ascending aorta is 3.35, 36. High bifurcation, thickened scallopy leaflets. Crossing could be a challenge. Eccentric calcification, asymmetric expansion. I'm going to let you ponder over all this and quickly start doing what we normally do. And then we'll pick up the discussion after that. Srini, am I going too fast? Ramesh, is this okay? Next slide.
Yeah.
Okay. Next slide. So here's the case plan. 22 balloon pre-dilatation, 34 core valve, no higher than 3 to 4 mm. There's a horrendous septal bulge. Can you see the echo on the screen? So when you look at the aortic valve, you can see asymmetric sinuses. You can see a pseudo-raphe between the LCC, RCC. You can see my pigtail going through towards the NCC, and look at the septal bulge on the image on the right. Can I have the 3D, Chandra sir? Look at that, play this. Look at that septal bulge. Back. So there's a big septal bulge, the next. So in the 3D you can again see it's looking like a bicuspid. With the raphe there where the arrow is pointing. So we have several challenges in this case. I'm not sure I'll be able to complete it in 20 minutes, but I thought what's the fun in showing a straightforward case? So you have large anatomy, you have less calcium, asymmetric calcium, bicuspid, added on rheumatic heart disease, moderate MS, moderate MR, mild MS, with a small cavity, highly irritable. Now I'm just going to move on and let...
Sai, excellent presentation.
Can
I
we have
want
the
to
fluoro
first
screen?
of all thank the entire team, Dr. YVC, Dr. Chandra sir, and Dr. Ganapati is there with you, and obviously the entire Karanya and
Show the fluoro.
MyLIC as well. So let me ask you, is there an AI in this valve or mild AI?
Yeah, yeah.
Right?
Yep.
Okay. On
Look,
the,
there is moderate, there's about mild, there's mild to moderate AI. You can see how irritable the LV is.
yeah, some question could be from the audience. I could say that maybe somebody will be saying, why
Before
would you want
I take the audience questions, Ramesh, before I take the audience questions, I'm going to first pre-dilate this valve. Could you handle the questions? Once I finish this, then I'll jump into any question that's there. Come. Or I'll try taking it on the fly. Go for it.
Why not 29?
So he's planning for 34 Revolute. I mean, can you do it with 29 Sapien? Yes, you can. The reasons probably will ask him as soon as he's completing that. But in the meantime, I mean, I also would prefer
TE probe out, Chandra sir.
as my
It's a bicuspid aortic valve. Oversizing can be a little bit, challenging.
So recent data that's coming up in the United States, I mean, Saurabh is also here from Portland, Oregon. So we know that in bicuspids, surgery
Go
is
negative.
still better than TAVR. But if there's anything to do with TAVR, whether it is either balloon expandable or self-expanding, both are equally good. It up
Say
to
fluoro.
somebody's preference, but I actually prefer balloon
Ready?
self-expandable valve in bicuspid valves.
Ready,
That's
Ganapati?
my own 2 cents. You know.
Ramesh,
Okay.
calcium will make a
Wonderful.
difference in balloon expandable
All
versus.
set?
We have Dr. Saurabh also here. Please come on.
Yeah, if there is
All
more
set?
LVOT calcium, there is a slightly higher chance of
Start
any
pacing.
root damage with the balloon expandable valve. Whereas with the self-expanding
Start
valve, I
pacing.
think we still have some time to decide whether you want to deploy it or not, and without causing much of harm.
Wait.
The
Start
balloon
pacing. I need the
expandable
pressure to drop more,
definitely causes a
Ganapati.
little bit harm.
So
Yeah.
you think that in a calcification,
Inflate.
preferably to have a self.
Oh, no, negative.
My preference.
Negative. Stop pacing.
Sai,
Stop
your
pacing.
choice also a balloon expandable valve or
I
a
think one of the staff
self-expandable.
Just 1 second, guys. Just 1 second.
This one, but I wanted to
How is
ask
the patient doing?
Saurabh, what is your
Look at the
choice
LV
of
apex
a
and
balloon
rasa.
expandable versus
Balloon deep dive.
self-expanding valves in calcified valves?
Yeah, hi Sai, it's Saurabh. I got on the podium as well.
Hey, Saurabh, how are you doing?
Good. So, we take a nuanced approach
Uh,
to this. In
Just
general,
1
I
sec.
think
Can we look at LV apex?
both valves work. Our slight preference for bicuspids. Now I'm sort of more in favor of a balloon expandable valve. But the thing to watch out here with balloon expandable valves is that the forces in these valves tend to be very
Let the pressure
asymmetric.
recover.
And therefore, we carefully watch the inflation pressure and don't exceed 6 atmospheres if you're going to do it that way. But certainly, this is a great choice for this patient.
Yeah, so the reason, okay, I'm going to come back to this, Saurabh. I'm just having some difficulty keeping the balloon in place because of the huge septal bulge. Give me a second. Guys, TE probe up. Okay, ready? Shall we try one more go? Ganapati, rapid pace. If you start slowly, once it makes contact,
So
go.
they're going to do pacing, which
Rapid
I
pace.
do recommend in all bicuspids, and whether it is
1 minute.
balloon expandable
1
or
minute.
self-expandable
Go up on the
valves,
pacing. I want
prefer,
go up YVC.
in bicuspid valves.
Go
I
up
want
fully,
to
full
do a
hog, full
predilation.
hog. Perfect. Negative.
Yes.
You do predilation.
Stop pacing.
Yeah, almost 100%
Excellent.
predilation in bicuspid valves and calcified valves. I also think that, long term, my views are, initially when we started off, we were using VAV to facilitate crossing the valve. And now I'm thinking more in terms of symmetric expansion and whether that has any implication on long-term structural valve durability. So my feeling is, and again, this is not based on any hard evidence in science, but that a symmetric expansion will likely have a lower incidence of structural valve
and how the aortic valve is
halt, which is something that we've been watching closely. So for the audience, if you haven't heard that word, it's basically hypertenuation leaflet thrombosis, and the gradients go up. Some people feel that it leads to structural valve deterioration. Hard to know just yet.
Can you hear me?
Yes.
So we did a good pre-drill.
Everyone's praising interesting.
Hey, Sushil, we can hear you.
Hey, Sushil.
No, I was just going to say, just real quick before, I think there's a lot of points being raised, and I think one of the challenges, all bicuspid valves aren't the same. And so to say, one valve or another, as everyone's been pointing out, you have to look at this valve. This valve is very different than that. It's very fibrotic. It will be hard to expand, and pre-dill is critical. And self-expanding versus, balloon expandable, there's just a lot to learn. The reality is, TAVRs are designed for circular annulus, and bicuspids by nature are not circular. So the challenge is to try and circularize something as balloon expandable, or do you put the self-expanding, which is going to interact differently. And so I think we have a lot to learn. Really, there's no dedicated bicuspid valve, especially in India and China. We need, there's a real need for this better understanding.
The recent position paper said about 45% is the bicuspid valve incidence in our country out of the cases which is buying, and even China also simulates the same pattern.
AP.
That's why I think US colleagues say that in their hospital, some of them say the bicuspids go for surgery. I feel all of you can learn from this data that bicuspid valves are also doing well with TAVR, because unless you have a particular reason, the patient is elderly, generally bicuspid valves are also being taken up like any other tricuspid valves in a country, and results are reasonably okay. But precautions like redilatation and whether the calcium is eccentric and sizing the valve properly, all that is important. The other thing what you said is assessment of the valve expansion in the various directions also is important. Sometimes it looks expanded. The Everett group I showed one case where it's totally expanded in another view. I think it's better to see it all through and then probably. I think we'll hear from Sai is crossing the valve. I think after dilatation that.
So you saw that we had some difficulties with the valve.
Sorry?
You had some, come to my left.
Yeah, it's a difficulty crossing.
One second.
Yeah.
It was a very difficult crossing. You saw that, Sushil? Go some more, Leo. That's fine,
Yes,
that's
yes.
fine. Slight caudal. So, give me a shot. Injection.
You're using LA
Go for it.
as your
I don't want to see
point of view.
Inject. I'm not using LAO caudal, Sushil. I'm just going to use plain LAO. Go some more LAO.
So, Ramesh, what are your, while
Okay.
he's positioning the
Ganapati,
valve, what are your thoughts on
give a
cusp
little caudal.
overlap, which we've routinely adopted now?
Yeah, we switched completely to cusp overlap now.
That's fine.
I think it
No,
is
that's
much
fine.
easier
Take
to
off your hands.
deploy. It takes hardly any time nowadays with the cusp overlap and much more precise deployment, as well as obviously initially we used to pace at 120. Now we start at 120, quickly dial up to 180 and dial back down. And I don't know, Sushil, are you following the same mechanism, cusp overlap and rapid pacing?
Ganapati, get ready to pace at 180.
Yeah, I mean, I'm not absolute
small
about
puff.
it. We do,
Save fluoro.
we do pace at 120 to stabilize the annulus. I think Sai is
Puff.
doing here. Cusp
Go down
overlap,
a little more.
in some views, I think whatever procedure, you want to standardize it, get used to it. And I think trying to get the implant depth at that 2 to 3, as Sai mentioned, is critical.
Small test.
And I think in many patients, cusp overlap can make that easier, but it's not always absolute, because sometimes you have parallax on the valve, and it makes it very
Shall we
difficult.
start pacing?
You don't come coaxial to the annulus, which makes it difficult. So you have to sort of adjust to the case and the patient, I think. Slow, controlled. The valve's going to try to dive deep, especially in these big bicuspids. If you don't adequately pre-dilate, those leaflets will prevent the valve from expanding, and that force can actually cause the valve to dive deeper as you deploy. That's why the pre-dilatation, I think, is critical in these cases.
Okay. Let the pressures come back.
Let's wait for the blood pressure to
What do you
recover.
think, Sushil?
It dove down, right? It went in a little bit more than
It
expected.
dove down. I wanted to keep it at 3 to 5. I didn't want it to be shallow because, the worst thing that you can do in a bicuspid is pop a 34. And the second thing is that I have a huge septal bulge, as you can see.
Yeah, but narrow QRS, I think let's wait
But
for
it-
Dr. Chandra to show us on the TEE and whether
No,
there's-
let me just wait for the pressures to come up. Then let's take a shot.
Yeah,
Less caudal. Less caudal. Less caudal. Yeah, don't worry. Okay, more LAO. Okay, that's fine. Okay, that's fine. That looks okay, but looks too deep, no, Sushil?
it looks deep, about maybe 8-10 millimeters.
I think it does.
Yeah.
It does look a little deep, and,
Can-
that is part of the struggle also with these
Can I have
rapid pacing. So we've changed the strategy to pace a little faster now, but then it just totally
deep.
arbitrates
Okay.
LV pressure for longer, and I think it accentuates the tendency for the valve to dive in. And 34 is notorious for diving in anyway.
No. Little bit, yeah. Pace. Yeah, now. Pace now. Keep pacing. Keep pacing. Keep pacing. Stop pacing. Better. Stop pacing.
Better than last. Yeah, looks good.
What do you think, guys? Looks good, right?
Yeah, definitely better than before, and maybe like 4 to 6 millimeters, I think.
Yeah, I don't want to put it higher than this, but I'm just going to wait for everything to come back up, and then we'll all take a call.
I mean, human
So I know that
dynamics-
if Ganesh was in the audience, he would have cringed.
No, so pre-dilatation, I think, was a question that we were asking earlier. Would you always pre-dilate 34 revolutes?
So I pre-dilate everything, Ramesh. I pre-dilate everything except a valve-in-valve or a pure AR.
Yeah.
I don't know what it is not to pre-dilate. So there are a couple of reasons why I do that. A, I get away with a smaller balloon in the pre. B, my post-dilatation incidence is less than 10%. C, it makes the procedure so much more stable and comfortable. And if you look at the initial core valve, it was mandatory to pre-dilate everything, right? So why change now?
Absolutely, I agree.
I mean,
So even with a solid full hog pre-dill with all of YVC's breakfast put into it, we saw how much difficulty I had to get the valve across. I actually had to counter tug the LV wire back and pop it in. I'll show it to you later, but I kind of like the position of this valve. I'm going to ask Professor Chandra to quickly look at it, and if you're happy, I'm going to drop this baby and then we'll talk.
Sort of, I think some people recommend
Injection?
waiting there in this position for 5 minutes till the valve expands and then do it. Do you wait longer
too deep,
before
huh?
you totally deploy, or you do it?
Yeah, I think in general it's a good idea to not release the valve right away. Just let it settle. It also helps the nitinol warm up to body temperature.
Huh?
But something that's been in there and
Too
then
deep,
it's a
right?
recapture, then I feel a little less worried about it. And in terms of the pre-dilatation, I personally am a big fan of pre-dilatation. I think that the approach to think about pre-dilatation just to facilitate
LCC is too
crossing
much.
alone
You capture again?
is,
have to catch.
is something that
That's
I've
very
personally moved away from. So for
Hey,
both
guys.
core valves and for Sapiens, I think we have a pretty high percentage of pre-dil.
I'm sorry, I got dropped
Sushil?
off for a second.
Saurabh?
Some of these cases, is it worth doing a Lunderquist wire? So do you ever use Lunderquist in these scenarios? Bicuspids, you're trying to hold it high.
Might be
we haven't done. I don't do it a lot. But
might be a good idea actually. I actually might be a good idea, but the LV was so irritable, Sushil, and I don't have space to shape a double curve Lunderquist, and if I don't shape it, the LV is so small that the soft part will come outside the aortic valve, and that's no good. By the way, just before we decide, I think this valve is again too deep. What do you think?
Inject.
I agree. I think I would try to get a little bit higher. I mean,
Yeah.
the concern is it's going to
So
drop further.
I'm going to try now,
as it
and
hits that leap with the
yeah.
shoulder.
So I'm going to now try and bring it. I'm going to try and bring it to 0 to 1 on the NCC because that's the only way I can get it to cant. The problem is it's a 34, so the confida doesn't have enough muscle to use
Right.
wire support to bend it over.
So
But I'm going to see what I can do.
I was going to ask
Okay?
you, like 34s, I always use Lunderquist. I don't know whether that would have given a little bit more stability, but still I think it can dive down. On TEE, it appears a little bit deeper than on iotogram. I still think we can start at 0 and see if it can position better.
I agree. Repositioning this to a slightly higher plane, somewhat right about there, seemed like a good spot. And there were reasonable calcium in the leaflet that I don't think
Your
will
pressure
move.
is low. Yeah. Sorry, Saurabh.
I know. Okay. Ganapati pressures.
Okay, that looks.
Guys, save the fluoro.
The challenge with the shape of the 34 valve compared to the 26 and 29 is that it has this. not
It's the
only does it
taper,
have a
yeah.
larger force for it to dive down, but the hourglass shape is more accentuated, so I think it has even more of a tendency to go deeper down after you release it.
I think we should accept this. Chandra sir, can you check on the echo? How is it? Guys, I think looking at this, I think I should accept this and not try once more. What do you think?
Yeah, I would not recapture multiple times. We already captured 3 times, right? This is the second recapture. But
Now, if I have to redo this properly, I have to take this out, put a Lunderquist, and then take the valve and go ahead and do it. Any suggestions,
no,
Sushil?
this looks good. I would do an iotogram
Saurabh?
here and an LAO and then deploy it.
Caudal. Caudal. Some slight caudal. Yeah. Yeah. Less LAO. Less LAO. Less LAO. Less LAO. That's fine.
There will be, I mean, there
Perfect.
may
Okay,
be
so
mild
we get an injection?
PVL, which is seen at 2 o'clock and the
What do you
short
think?
axis.
What do you think?
That looks good.
I mean, I think you're on the inner curve. The left is what looks low. You're on the inner curves, and the left should come
Yeah,
up
the left looks low and it's on the inner curve.
Yeah.
Yeah.
Huh?
So you're in the inner curvature.
So what do you want me to do?
I think Sushil is saying that you have to deploy it very slowly and maybe with a little bit forward pressure.
See whatever I deploy, this valve is so big, it will either fall to the left and go deeper on the NCC, or it will pop higher up on the LCC. There's no way of telling. Especially with the less calcium and the way it's been diving, if I was a betting man, I'd say it's going to dive deeper. So
That's my
if I
concern
really
that
want to get this valve, right, probably what I should do is forget about completing the case live, take the valve out, get Thiru to prepare it, go back in with a Lunderquist, get it on the outer curvature, and deploy it nice and shallow. What do you guys think?
I think you'll be okay by deploying it in this position. Pull the nose cone back into the centralize the nose cone, and with a little bit forward pressure by the first operator and rapid pacing, you should be able to deploy it.
If I
I
give
mean,
forward
you should
pressure,
do
I'm a
what
little
you-
worried
what
the
you
valve
feel-
will go
what you
deeper than
feel
it is.
comfortable. Yeah. Yeah. Now, and you should do
No,
it.
try one
You
more
should do what
recapture.
you feel comfortable, obviously. But I think your point that if you want to try again, you got to change things and try something different is an important point. Redoing the same, I think, doesn't make sense. I think your idea that if you want to try something
Over and over
different,
again
that
doing the
makes
same
sense.
thing. Yeah.
Yeah.
So the reason why I'm not comfortable with letting this valve go here is that you know this one has a tendency to dive down. And I'm already at 6 millimeters on the NCC and probably at 8 or 9 on the LCC. So I think that if I drop it, there's a good possibility that the NCC might dive deeper and settle down at 8 or 9.
I'm not so much worried. I think it'll tilt a little bit more towards the, it'll come back up on the left
Okay.
side. Yeah.
All right, Professor Chandra, how are you at the depth? How is it on the septal side? How many millimeters? See, did you see how high I came up while I did the partial recapture?
Yes. Yeah.
No, it can't be 11 Chandra, right? So I can't go shallower than that, right? Give me an injection.
Maybe get the TE probe up and inject.
I'm not going to let
The
this
left
valve
is
go
very
here.
low, right?
Yeah, but Sushil, I'm not going to let the valve go
I
here.
would agree.
Going down.
Yeah.
Okay, I'm
I
not
think
going to let the
coming
valve
up
go
is
here. If you guys want to go and come back, yeah, I think so.
I think that's a good
Ganapati,
idea.
TE probe up, Chandra sir.
We should do more.
I'm going to try just one more with wire.
Yeah.
Okay,
With 0 we try.
I'm at 0. I'm at 0. I'm at 0. I'm at 0. I'm still at 0. I know, I'm doing that. I'm at 0. Pressure should come back now. Okay. Can you get pressures back, Ganapati?
I think that
Inject. Correct the parallax. More caudal. Go more LAO.
This looks a lot better to me.
Okay, stop. Yeah, I know. Let him breathe. Huh? This is the best I think we'll ever get. Why are you not injecting, ma? Inject. Yeah, I think this is the best we'll ever get.
I would suggest taking this one.
Ganapati, let him recover. Yeah, let it settle because I've done 4 recaptures. I want that nitinol to settle before I let it go. I've realized these 34s are like trucks, right? And there's no hurry now. Patient is stable. Pressures are coming back. I've got a good position on the NCC. I'm going to take my time, let the BP come up. I'm going to let Professor Chandra do his thing with the echo. And then with gentle forward pressure, I'm going to let it go. 1 minute. Mile, can one tech change the fluid? And can you give me go less caudal, Mile. Less caudal? Yeah, that's fine. Go a little more LAO. Less caudal. LAO, that's fine. That looks good. Okay.
There is no depth.
Can I take that depth looks nice. What do you think, guys?
We agree with this. This looks really close to perfect size. And we
Okay,
suggest just
super.
taking it.
Now I'm just going to dot all the. Yeah, I'm going to dot all the I's, cross all the T's. I've released the tension in the system. It's a 34. I've floated the wire back into the LV cavity. Let the hemodynamics come up a little, and then I'm going to slowly drop this baby.
Now, do you pace at release? Let me ask.
So, absolutely.
What what about you, Ramesh and Sushil?
So what I do is
Do you pace at release on these all the time or some of the time?
No, absolutely 180. I don't hesitate pacing at all nowadays. I don't think any reason not to. And
Yeah,
Sushil.
I pace as well. I pace as well, but I want to make one quick comment. You know, I think the speed of deployment of that last, when Sai did this last repositioning was perfect. And you can't rush when they're hypotensive. You got to hold that position, and the pressure will come back. You just have to. But the pressure came back because the patient wasn't hypotensive going in. So making sure the hemodynamics are good when you do this stuff, and letting the patient breathe in between recaptures, those are all key components. I guess the one question I would have here is, you're still in the inner curve a bit, not as much as worked before. Are you pushing forward? Are you releasing any of that inner curve, or are you going to just?
yes, I'm going to push forward. So you know what? If you notice what I've done already, I've moved the wire back up, and I've already pushed out a little and brought it to the center of the cavity. See, while you were talking. Now the reason why I didn't want to do that too quickly is because I want that 34 to. I want that 34 to get that fan-like shape. Once it gets its conical shape like the core valve that it's built to be, I like to use it to my advantage and push down a little, hoping that it will hold, and I'll release it very slowly in rapid pacing with that push. I still want to end up only at 5/6, Sushil. I don't want to pop this valve into that ascending aorta.
Yeah, no.
But if you notice what I did when I did,
Great point.
I don't do full recaptures anymore. You know, and that's why I wait in between for the pressure to come up, like you said, and then I just use the wire, I give tension on the wire, and I just allow it to float out. And if you notice, the key here is not to get flustered. What are those bubbles? Okay, patient's all right, right? Yeah. Okay, good. Can I see the depth, Chandrasa, how it is? Sorry, Sushil. So what I like to do, the most important thing again, like here is that, see, there's nothing gained from panicking that he's hypotensive. Because if I release that valve any slower, the rotational force is going to drive it into the LV. So my only hope is to make him hypotensive, use the hypotension because the cardiac output is all choked up, the valve is not going to bounce too much, and try and get it as good as I can. Guys, Cine, injection for fluoro. What do you think? It's moved in a little. But I should take it, huh?
Yes.
It still looks pretty good. I think this seems as good as we could get.
Okay. Rapid pace. Ready? Don't worry. Slide forward pressure.
Yeah.
Slide forward pressure.
I think gradually it will settle
Okay.
align itself.
Stop. Stop pacing.
Yeah.
Quiet.
Yeah.
Safe.
Yeah, that's
What
a
do you
very
think, guys?
That's a very good deployment, Sai. I think everything went very well, and you did it a perfect job. And this patient, and the QRS is still narrow, and the blood pressure is recovering. And as we expected, there will be some mild AI because of the chunk of calcium, but excellent demonstration of a 34 valve in this complex bicuspid patient. Any last comments from Sushil,
No
and
problem.
then we'll move on to the next live
No
case.
problem.
And thanks to your entire
No problem.
team, Sai, Dr. Chandra,
Bless-
Dr.
bless
Ganapati,
Elio.
and Dr. YVC.
Hey guys, I hope you guys didn't mind that I put a nice complex case because I thought what's the fun in showing something straightforward.
No, great. 34 valves
Shall we
is
do a
most
shot?
difficult to be done, and it's done well. Thank you, Sai.
Yeah, why don't we get one last shot before we go? One last shot before we go, just to see the depth.
I know. I was wondering why Sushil is keeping quiet. Okay. Can I have a little less, Elio? More AP? More AP? Little caudal. Little caudal. Less smile. Little caudal. Yeah.
Can we get the echo probe up for a second?
Okay. Yeah, Chandra sir, echo probe up for a second. Yeah, okay. He's behaving okay, no, Gana? Yeah. He's okay, right? Okay, good. Okay. Echo probe up, Chandra sir. Inject.
But it's deep that side.
It's a little deep on the LCC, huh, Sushil?
It's a little deep.
But there's a good seal.
Yeah, but there's no leak. There's no leak. You get good coordinated flow.
See, there's no...
You know, again,
There,
yeah.
take it off.
Check hemodynamics. This is good.
I like it. You know what? Considering how complex this case was, he's absolutely unfit for surgery. I don't think we could have got a better result than what we have got, because you've seen the number of recaptures, right?
Thank you, Sai. I think though a little deep on the other side, the hemodynamics are good and ECG is all right. And congratulations, thank you. We'll be.
Hey, thank you all so much. Thank you, Sushil. Dr. Pratap, thank you. Ramesh, thank you all.
Thank you.
Thank you.
Sai, we are with you. We wanted to show the hemodynamics for some time, then we'll move on to other center.
Yeah. Bring the hemodynamics. Okay, so I just didn't get to say bye. Thank you so much. But very quickly, I just wanted to show you the hemodynamics. And you know, when I started the case, somebody asked me why I chose a self-expanding valve for this case. So you saw all the challenges: complex anatomy, bicuspid, fibrous tissue, and big septal bulge, small LVOT, irritable septum. In spite of all this, we could control the valve. Yes, it tended to go down a little, but when we finished the case, show the echo on this right side. When we finished the case, look at the hemodynamics. Zero gradient, slight QR prolongation, we have an LBBB, and the echo shows a nice circularity with no longitudinal compression of the valve. There you go.
Thank you. Excellent hemodynamics. That's the advantage of self-expanding, I think. Very well demonstrated. Thank you, Sai. Can we move to...
Thank you so much. Bye, Sushil.
Thank you. Bye. Can we move to
Bye,
the
guys.
MGF?
Ramesh, Pratap, bye.
Thank you.